I could even greet you this afternoon in the languages of the French and the Spanish people, bonjour and buenas tardes. But I greet you today with the word salvona. And I use that word particularly because when saying salvona, we really are saying that we see each other. And this celebration of this inaugural lecture is really about seeing each other, seeing our scholars differently, and particularly on this occasion, seeing Professor Brenda Morrow in a particular way. But Sisi Salvona again to the family from which she comes and their contribution to who she has become as a scholar. And then to the community gathered around her, we say Salvona because we see them and the contribution they have made to her scholarship. And importantly, this occasion of the inaugural is really the celebration. Here we see how Brenda's own work crosses the disciplines of physiotherapy and the intensive care discipline as we know it. And so this afternoon I really take the time to come and preach in a particular way. And just to say that an inaugural lecture is an important moment in the life of the faculty, but also in the life of the scholar. And now I want to hand over to Associate Professor Tracy Maledi, the Deputy Dean for Social Accountability and Health Systems, to welcome you more formally and more intimately to this celebration. They will stand for the duration of the lecture as far as I can keep connection. Thank you and welcome to this event.
Thank you, Dean. Dumelang, Lochani, Moreni, Good afternoon. As you've heard, I'm Tracy Naledi, the Deputy Dean for Social Accountability, and it's the first time I officiate in an inaugural, so I'm very excited. I've been dressed up for the part. Hope you appreciate my effort. Welcome, Tavedes, as the First Nations would say, Namgelekile, Endawenyas in Kwenkwezi, the Sterava, a place of the stars, if Kamerodichas, as it was first called by the First Nations. Welcome to Prof. Morrow's family. Welcome, Carl. It's such a small world. I realized that I actually worked with Carl at Desmond Tutu HIV Foundation. Welcome to Tia, to Isla. Welcome to the grandparents, Ethel and Diana. Welcome, Grandpa Jasper over there at the back. Welcome, everybody. We welcome in particular acting HOD, Professor Mignon. I did practice, now I'm nervous. Professor Rudzani is out of the country as well and also sends his greetings to any members of the Dean's Management Committee, our faculty board, any of our student representative bodies, our colleagues, past and current, our partners from the province and any of the civil society that we work with, our community and our friends. Special welcome to Prof. Argent, who's the former HOD of the department. Welcome and all protocol observed. Our faculty is situated in an area called Observatory, on the foot of the Devil's Peak, close to the sacred lands of the Khoisan people, where the Black River meets the Lesbic River, where our First Nations, our first people, came to gaze into the sky of stars that was unraveling the secrets of nature, dreaming of the pride and joy of future generations, that's us, who will live in peace and freedom and a deep connection to one another. As a saying in my language, isiZulu goes, Ngingumuntu ngomuntu ngabanye abantu. I am because you are. So we are all deeply connected, and I'm very grateful for this moment today. We are here at the Faculty of Health Sciences. Here we see ourselves as part of a galaxy. We are stars in our own galaxy, all of us. No one is greater than the other. We are all unique, and we all have a unique place, and we all shine together to light a path to innovation, to discovery, to service towards health equity and social justice. An inaugural lecture, as the Dean has said, gives us an opportunity to celebrate one of our stars, Prof. Morrow, the professor who has recently, though I was reading that you got your professorship in 2018, so it's not quite recent, thanks to COVID, but it's supposed to be recent. Let's pretend that you were only recently appointed. It's a time where, as a professor, you profess your knowledge to a lay your fellow academics. It's an opportunity for us to understand you as a colleague, a place, and your positioning in the stars. It's an opportunity for us to understand your life's work and your contributions. An opportunity to value your light that shines bright on a path to inquiry, to discovery, innovation, and service. A light inspiring others to find their own light for them to shine bright as you are. As part of the 110-year anniversary celebrations of our faculty, the Dean has purposefully foregrounded stories that we would ordinarily not have not been heard not so long ago, and not in such a distant past. It is quite apt, therefore, that the stories that we've heard so far in many of these inaugural lectures have been stories that have foregrounded women who have done extraordinary work, contributed to the advancement of science, of health, of discovery, and social justice. So on the 65th anniversary of physiotherapy at UCT, I'm so pleased today for us to be celebrating Prof. Morrow, a physiotherapist, a clinician scientist. I would therefore like to welcome Professor Mignon, who will formally introduce Professor Morrow.
Good afternoon, everybody, and thank you, Professor Milady, for such a wonderful welcome. I'm just going to say all protocol observed. And I really want to just echo what Lionel said in terms as the Dean. It is so lovely to see each other face to face. So welcome to everybody here. Welcome to all those people online, because I feel like there's a hidden group of angels who are watching on the skywaves. But specifically, Brenda, welcome to you and to your family, to Carl, to Tia, to Isla, to Diana, to Ethel, and to Jasper sitting in the back. And to all your colleagues, and just the fact that there are such a varied group of people here just shows how much you are loved, what a huge difference you've actually made to the community around you. And so this is your day, this is your very special day. I know it should have happened in 2018, but let's pretend. So you are going to be speaking to us about physiotherapy in PICU and moving with the evidence into the 21st century and beyond. So Carl, thank you for allowing me to collude with you, and Brenda, thank you for being my friend on Facebook. as well. And so Brenda's journey, and you may notice that Brenda is hardly aged. She's just And so 1992 to 95, she did a Bachelor of Science. She then, thankfully, became a physiotherapist at the Red Cross Memorial Children's Hospital. How lucky were we that she got a job there? She then registered for a Master's of Science degree in the Division of Physio, and she was supervised by Andrew and she by Dr. Potter, but then was doing such great work that she upgraded her MSc to a PhD. And the topic was investigation into non-bronchoscopic bronchoalveolar lavage, I managed to get that out, and endotracheal suctioning in critically ill infants and children, and supervised by the same team. She then went on to become a part-time senior lecturer in cardiopulmonary rehabilitation. She then became a postdoc research fellow. She then became a UCT senior lecturer in 2013 and an associate professor, and also a Career Award fellow. And then in 2014, as if physiotherapy wasn't quite enough, with distinction, she got a postgraduate diploma in human research ethics. I have ethics envy, because it's a really important part of the work we do, specifically working with children. And then, as if that wasn't enough, very recently during COVID, what did she do a diploma in palliative care medicine. So that was really amazing. And what I meant to say, Brenda, when I welcome people, I half expected some of your menagerie to be here as well, because I know you have a large number of pets, but we'll come back to that. So her promotion as associate professor initially, and then full professor more recently, and that is what we are celebrating tonight. So what has she done to be awarded this? The fact that she's done an amazing amount of research output. Her H-index 27, and you can see there all the stats up in front of you, 116 papers. I haven't even gone into how many chapters in books, how many publications, how many abstracts, how many presentations at congresses. We would be here all night. and I know we're going to go short of time, as after all, Brenda is here to present her work. She's also been a teacher and a supervisor, and I can believe how many people she supervises, because Joy seems so calm. I think I'd be fairly hysterical if I had this number of people that I needed to supervise, but not just in physio, also more recently now health research ethics. She's got master students and a good number of doctoral students as well. So Brenda, an amazing teacher and supervisor, and with permission, you can see Brenda here doing some teaching in the skills lab at Red Cross on the left, visits to Ghana together with Samir and with Marcus and Purdy as part of the African Fellowship Program, doing lots of outreach and literally teaching her socks off, feeling so hot and bothered and then had to put her feet up because it was really a lot of stuff. And then, because she's such an adventurous, inquiring mind, she ended up in the jungle with Marcus and Purdy. I presume it's a rainforest in Ghana, which I've visited as well. So, but for me, what is special about Brenda is her ability to work in different teams of people. So she's been very much part of the intensive care team. She's very much part of the pulmonology team. At the bottom, the Cystic Fibrosis Clinic, and then on the right-hand side, the European Cystic Fibrosis Congress, attending and meeting up with all buddies and friends. When it comes to congresses, so she has attended multiple congresses. Again, I started listing them and then it just got out of hand. She has gone to physio congresses. She's been on the scientific committee of physio, critical care, more recently palliative care. So she doesn't just stick to one topic. And very excitingly, in July of this year, she was the co-chair with Andrew of the WFIX, the World Federation of Pediatric Intensive Care and Critical Cardiac Society, which unfortunately was held virtually. She's also on the Executive Council of the Critical Care Society, and now currently the President of WFIX International. So we're really very, very proud of our own Brenda Morrow. But keeping it really down to basics, here is one of our patients, Musa Mtseleng, who's now 30. She got a combined liver kidney transplant, and at the beginning of the Congress at WFIX, we actually had her and her mom on a fantastic webinar with Brenda and myself and Andrew, and just walking through her journey in ICU. And I think the personal touch that you show just shows what an amazing person you are. So that is a credit to you. You also made WFIX amazing. There was dancing at the beginning of WFIX in your household. I'm trying not to show that picture. And that was a great way to start, and Brenda is now the current president. Going back from a university and social responsibility, this is a picture of Brenda in her 1995 Sedgefield elective, in a little ambulance, doing some work. And you can just see she's on many of the university departments, research ethics, board for graduate studies, very much part of the APFP program, but lots of outreach. And I know whenever, so Brenda's office is opposite mine, whenever she's not there, she's inevitably on a plane going somewhere in Africa to go and visit her students. So you mentioned Ubuntu. I am, because we are, and I really love this slide. That really describes Brenda. But for me, it is such an honor to be able to present her, and I know I'm not as handsome as our head of department, who's on the but I'm trying. And this picture, I know was supposed to be the academic stuff, but this is a picture that I think I took at Delbrook one morning, where we swim on a Wednesday morning at dawn. And also a delightful picture of Piper, her dog. He does agility competitions and often wins her some prizes. So I haven't got all your pets up here, but I just wanted to end with your family. Thank you for being such a very proud family, and thank you for keeping Brenda very proud. And I'm going to hand over to Andrew to complete, no, sorry, to Brenda to do your presentation, and then Andrew will come back to what a nice person.
Thank you to Professor Lionel Thompson, Dean, online, Associate Professor Naledi, to Mignon McCullough, to Professor McCullough, almost unobserved, and Prof. Andrew Argent, colleagues, friends, and I think even an old patient of mine in the room. Thank you very much for being here tonight. When I started preparing working this inaugural, it was quite difficult to decide what to focus on. So Mignon's talked about some of the pies that I have my fingers in. And although I do have my fingers in a number of different pies, I think, self-identify primarily as a pediatric physiotherapist, which is the field that I trained in and in which I still practice today. Within that field, though, I have multiple research and clinical interests, and I think some of that you've heard from Mignon very kindly. In pediatric critical care, cystic fibrosis, neuromuscular diseases, general pediatrics, and ethics. And if we break that down a little bit more, you'll see that there's quite a bit more that comes out. And so this might speak to some sort of attention deficit issues. I clearly can't focus on any one thing, but it also keeps me entertained and out of mischief. But in order to keep some elements of coherence and continuity, I've chosen to focus on the area that really started my research interest, the pediatric intensive care unit. And particularly, I want to provide a snapshot of the evolving role of cardiopulmonary or chest physiotherapy in that clinical area. I'm going to take you back to long before my time, to 1903, when some momentous things happened. So as some of you will know, the Wright brothers made the first powered flight. Marie Curie won 1/4 of a Nobel Prize, and a rather obscure recommendation was published in the journal Transactions of the American Pediatric Society, describing a case that this Dr. Sanders had seen of a newborn child with acquired atelectasis, lung collapse. In such cases, there is nothing, he found out, as efficacious as flagellation. I believe that this may have been a precursor to chest physiotherapy, as many people understand it. By 1915, the idea of physiotherapy had gained popular attention. So this advertisement invites people to join the physiotherapy profession, to be your own boss, to have nicer work, and to be a person of importance in your community. It refers to the new demand for drugless healing. It says it's really easy to learn. It needs no unusual manual skill, no supervised and finishes by saying that the principles are completely founded in scientific fact that are known to everybody, and so it's evidence-based. Which is fantastic. So, I became a physiotherapist. Fast forward to 1996, when fresh out of the UCT Physio School, I started working at Red Cross War Memorial Children's Hospital in the old E1 intensive care unit. I idealistically believed that everything I'd been taught at physio school was in fact correct and evidence-based and founded in accepted scientific principles. And I dutifully followed the established protocols. Every ventilated child and every child unfortunate enough to be admitted with a lower respiratory tract infection was referred for chest physiotherapy. Every single one. Chest physiotherapy generally involved positioning those children in strange ways, sometimes head down, clapping, percussing their chests, and then sticking a hose pipe down their airways to clear the secretions. In about my first month of working, a 3-year-old looked at me and said, "Tani, can I be a slut? Are you coming to hit me again?" At which stage I think I had my first misgivings. And then I realized that my referral letters were less than professional. Consultants would ask us to come and bash this child, beat this child, give aggressive physiotherapy to this child. And then my misgivings became even worse. It's uncomfortable putting these pictures together. But I did start to ask the question, are we really doing the best for children? Do we really have to be cruel to be kind? And is there perhaps a better way of doing things? Luckily, I had mentors like Andrew Argent in the front row here, who supported my questioning, and he probably got sick of it because after a while he pretty much told me to stop asking questions and go and find the answers. and so that's where the research journey started. And we really have started to challenge some of the existing paradigms, which is quite exciting. Sorry, I'm just making a noise. So one of the things I still do now is ask the question why. I don't think I ever got out of that toddler phase of asking why. And when I started working, I was still asking why. Why are we doing this? And I think it's important to understand why people felt that these children chose chest physio in the first place. Because in understanding why we're doing things, perhaps we could work out better ways to do them. In the 1990s, certainly, physiotherapists were often seen, I think, as glorified snot suckers. It was all about the mucus. And in fact, my brother, in the census at the time, put this as my profession. And some people say surgeons have no sense of humor. But the question is, does chest physiotherapy work to get the mucus out? And more importantly, so what? Why do we want to get the mucus out? Is it in any way helpful? Does it help the patient, benefit the patient in any meaningful way? So to determine efficacy or effectiveness, we need to start interrogating the evidence. And so we started looking for strong empirical research in the form of randomized controlled trials and systematic reviews, because this is medicine, right? We have evidence. Unfortunately, at that time, and even to this day, there is very, very little empirical evidence available. This study from 2004 may still be the best that we have in terms of chest physiotherapy effectiveness. It was written by Eleanor Main and colleagues who, interestingly, also trained at Red Cross Children's Hospital. And this study compared endotracheal suctioning to chest physio with suctioning. And they did find that the chest physio was associated with improved airway resistance, some changes in tidal volumes, and respiratory compliance, but there was no difference at all in blood gases, really making you question what the relevance is of some of those changes. So Andrew and I were asked to write the accompanying editorial for this paper, and really it was interesting because we really got to grips with the minutiae of their study, and we realized that they had observed what we had been seeing in practice, that some children clearly did respond to chest physio. Some children got a whole lot worse. And then there was a whole lot in the middle where it seemed to make absolutely no difference. What was more concerning, though, in this paper is that almost a third of their participants deteriorated following both interventions. And even in retrospect, the authors couldn't identify who was more or less likely to respond to treatment. So there really was, and there still is, no robust evidence using any relevant clinical outcome measures that supports the routine use of chest physio in children with acute respiratory disease. And the same goes for adult patients. So should we be doing it at all? Well, we also know that simply not having evidence of effect is not the same as having evidence that it doesn't. And most people who have worked in the field have stories similar to this one. A child with acute lung collapse post-surgery. I was called in the middle of the night, you can see the timestamp there, 11 o'clock at night, and was able to very quickly clear a large bronchial obstruction, to almost completely re-expand that collapsed lung very quickly. And this allowed the child to be extubated, to have the ventilator removed the next day, and was discharged from the ICU the following afternoon. So this kind of makes us feel like superheroes. It also means that people are more likely to refer patients to us, because clearly we can work magic. So if chest physio can make such an impressive difference to some children, shouldn't we then just use it on everyone? I mean, it's just physio. What could possibly go wrong? But it turns out that while there's very little supporting evidence for the benefits of chest physio, there are numerous reports of harm going way back before the 1980s. A search of the literature identifies all of these papers describing serious risks of chest physio, some of them really serious, including hypoxia, increased metabolic demand, increased oxygen consumption, cardiac arrhythmias, changes in intracranial pressure and brain oxygenation, reflux and aspiration, pneumothoraces, got rib fractures, and then the small one at the bottom. Children have died in response to chest physio and suctioning alone. So the list of complications again made me worry more. Did the risks of harm completely outweigh any potential benefits? And when would it, or might it be, appropriate to treat? So if you remember the evidence pyramid, we know that there was no high-level empirical evidence of effectiveness, but you have to go back down that pyramid to look for physiological evidence or plausibility for why we want to do things. And really we can go to basics in terms of the mucociliary clearance mechanism, which functions really somewhat like an escalator. So together with a coordinated sweep by the cilia, the little hairs in the airways, along with dynamic airway compression that causes accelerated flow on exhalation, all the debris in the airways moves upwards in a coordinated fashion in a normal mucociliary clearance system. But we also know that this clearance system can become overloaded. It can become overloaded by excessive secretions, by very fixed secretions, in the face of ciliary damage, for example, by applying cold, dry, unhumidified gases, and in the face of infection and inflammation. When that mucociliary clearance mechanism is challenged in respiratory disease, children usually try and respond by coughing. And coughing is a completely normal, protective mechanism for the airways. But the problem is that the cough itself can become ineffective and tiring to the child, especially when it's out of proportion to the amount of secretions that are there. The other problem is that the cough, by its very nature, because of the high pressures and flows that it generates, can cause dynamic compression of the airways, effectively trapping secretions and air distantly, limiting the effectiveness of that cough. If we add to that a tube, so we need to intubate children in order to mechanically ventilate them, having a tube in the airways stops the ability to close the glottis, which is a really, really important part of the cough mechanism. So when you're coughing, you take a deep breath in, the glottis closes, and that's where the pressure buildup occurs. So if you don't have glottis closure, you can't have an effective cough. So when you have retention of secretions in the face of mucociliary clearance deficits, this can lead to airway obstruction, which has potentially harmful consequences, including further infection, further inflammation, lung collapse, ventilation and perfusion mismatch, and effects on gaseous exchange. It increases the child's work of breathing and can lead to or exacerbate respiratory failure. For a child that's being ventilated in the ICU, this may prolong the requirement of mechanical ventilation, which also has a number of complications attached, and may even lead to chronic lung disease. So it makes sense then, where there is airway obstruction that cannot be cleared through a normal mucociliary clearance or through a cough, that helping that clearance may be beneficial to prevent some of those complications. But this also, I think, quite clearly shows that applying chest physio in the absence of secretion, so where there is no obstruction, is not going to be helpful for the child and may cause harm. Furthermore, prophylactic chest physio doesn't seem to make sense here. If there are no secretions, or if there's a normal mucociliary clearance mechanism and a normal cough, those children do not need assistance in clearance. In 2004, the year I graded to a PhD, Louise Lanafors wrote quite a seminal paper on the mechanisms underlying effective airway clearance therapy. This was actually applied in the cystic fibrosis arena, which you've seen as one of my other loves. So newer airway clearance techniques really rely on three different mechanisms. The first is the mechanism to open up the lungs and to get air behind the secretions. Once that has happened, we then need to mobilize secretions from the peripheries to the central airways. And once the secretions are in the central airways, we then need to help clear them from the airways so that they don't get re-aspirated or cause further upper airway obstruction. And this is where my journey started, as you heard from Mignon. My PhD was largely focused on endotracheal suctioning and a related procedure, the non-bronchoscopic bronchoalveolar lavage, which is just too long to talk about really. So when I started working in the 1990s in terms of endotracheal suctioning, really not much had changed at all since the 1950s, both in terms of technique and equipment. So suction was considered completely routine. I must just say as well, sorry, that all the photographs of clinical patients were taken with permission from the parent. Suction was considered routine. All ventilated children were suctioned every hour on the hour. There's a little box at the bottom of the obs where you have to fill in what was suctioned. That's regardless of whether there were actually secretions or not. And in addition, children who received chest physio would also all get suctioned, regardless of whether there were secretions or not. Again, I started to worry after I had to intervene on, the 50th child who had desaturated during suctioning, whose heart rate had dropped to dangerous levels. And certainly in the wards, there were children that actually denied following suctioning as well. So I became really worried about this practice of routine suctioning and the potential harm that it was doing. So we now know, thanks to quite a bit of our work, which I say contributed to half of my PhD, that although suctioning is a very frequent and common intervention in the ICU, and it remains so, it's not without risks. It's not a benign procedure. Suctioning alone, without any other systems in the body. Can cause raised intracranial pressure, can cause mucosal trauma, even pneumothoraces. You can see a little granuloma in the middle picture. You can see the little bump in the middle. Causing lung collapse every time you suction down. Can cause arrhythmias, bradycardias. And importantly, it's very uncomfortable and it's sore. It's painful. I have suctioned myself. I'm one of the few physios that actually has. It's not nice. So I won't lie to my patients anymore about it. And suctioning, in fact, is one of the procedures that is reported to be the most traumatic intervention in critical care. Patients frequently suffer from post-traumatic stress disorder after ICU discharge, and in fact, suctioning is the one intervention that they most commonly report as being the worst. So our first papers, our first research was quite interesting because we started off using a very basic lung model. I think Anne found it in the back of the cupboard somewhere. And then we moved on to looking at children and looking at the effects specifically of endotracheal suctioning on lung dynamics, on compliance and resistance, and on hemodynamics in critically ill ventilated pediatric patients. And what we showed was quite alarming. That we saw that every time we disconnected from the ventilator and lost positive expiratory pressure, we lost a little bit of pressure, the lungs de-recruited, we lost volume in the lungs. We added that suction to that, and we further lost volume in the lungs. It was returned after reconnecting to the ventilator, but the lungs had in the interim gone collapsed and then reignited. We saw that this was worse in very small infants with very small tubes, where the catheter is relatively bigger compared to the endotracheal tube, and where we apply very high pressures. And importantly, we saw it was much worse when suction was applied in the absence of secretions. It makes sense, complete sense, that if there's secretions blocking the catheter, you're not applying pressure to the lungs anymore, right? But if you're suctioning and there's no secretions there, all of the negative pressure is transmitted to the lungs, causing collapse. So it sounds simple, but it was quite important. We also had a bit of a light bulb moment because a little bit earlier, actually this is the time when I started my undergraduate studies, in adults specifically, this term, open the lung and keep the lung open, was coined. So this is an important concept in lung protective ventilation. It became an awareness gradually that actually the practice of mechanical ventilation, where you open and close the lung every time you apply the breath, was causing shear forces and injury, stress and strain injury in the lungs, which is actually causing severe damage to the lungs. And it's changed ventilation practice in terms of lung protective ventilation, where we maintain a positive end expiratory pressure and we try and limit the extremes of opening and closing to protect the lungs. But we realized that in fact, by applying suctioning routinely every hour, we were contributing to a cyclical inflation and deflation that could be causing lung damage. So we started looking at ways that we could ameliorate those adverse effects. We started by trying to see if we could apply a recruitment maneuver after suctioning, and if that would reverse what we had done. If we tried to re-expand the lung, if that would help. Unfortunately, it didn't really, because the lungs would re-expand themselves after connection to the ventilator anyway. And so we were still opening and closing the lungs. We looked at closed system suctioning, which was being put forward by various companies as the answer, because in this system, you don't have to disconnect from the ventilator. The ventilator continues while you suction. Unfortunately, though, in terms of protecting volumes, closed system suctioning didn't seem to work. And it's likely because, being a closed system, air can no longer come in to replace what you're suctioning out. And so in some cases, particularly very small infants, using a closed system made it worse. It in fact made the volumes worse. So we often get upset when we get negative findings, but it's useful because it makes you think about what you can do to change practice in the real terms. So from the start, my interest in research really was to make a difference clinically. I'd never set out to be standing here in a funny red cloak. I really just wanted to make small changes and to try and improve the experience that children had in the intensive care unit. And so to try and make change, you need to translate it. So we wrote the first guidelines for endotracheal suctioning in 2008. And these were updated last year in collaboration with an Australian group, which was very exciting. So I helped Jess Schultz get her PhD. She's a critical care nurse in Australia. And essentially, we have now shown that very small interventions can make a big difference in endotracheal suctioning. Small things like pre-oxygenation, like choosing your suction catheter appropriately, making sure that you're not putting a high pressure on. And perhaps most importantly, and this message is going to come back time and time again, ditch the routine. Routine suctioning in the absence of secretions is harmful and not beneficial to patients. So this was quite a shift in practice. And that's taken hold now throughout the world, that practice has changed, which is quite nice. So back to the first phase of airway clearance is opening up the airways to get air behind secretions. So we want to do this firstly to use the force of airflow to move secretions upwards, to help to ventilate areas beyond where the obstruction is. We also want to make sure that we are properly matching where the air goes and where the blood is going. So ventilation and perfusion matching. And if you get that wrong, you're not going to help the child in the long run. So how do we do this? How do we make sure that we get the air to the places we want it to go to, both to clear secretions and to optimize ventilation and perfusion matching? Well, we look at body positioning, which is a really simple thing to do, right? It's completely free. It's available for everybody to use in every context. So what position would you use in order to direct ventilation to a particular area in the lungs? Well, this is quite interesting, and it might be counterintuitive. In adults, the pattern of preferential ventilation to the deep end, the bottom lung region, is actually very well described and documented. And this pattern arises because of a vertical gradient in the pleural pressure in both the upright and the side lying position. So the dependent lung portions essentially have lower resting volumes and are therefore able to expand more during expiration at lower pressures than the uppermost regions. It's a little bit like a slinky toy. You all know the slinky toys. You can see the coils at the bottom are quite close together. They've got the potential to expand, whereas the ones at the top are really far apart and they're not moving anymore. Interestingly, if we completely paralyze adults, this pattern changes because they move down the pressure volume curve and become less compliant, and so the pattern shifts again. So this is in adults. Spontaneously breathing adults preferentially ventilate the bottom lung, in side lying in an upright position. But what about children? What happens with them? Well, for years we based pediatric positioning practice on the findings of some very old studies that used krypton ventilation scanning in the 1980s, 1981 and 1985. So these researchers reported that all infants and children had the opposite pattern of ventilation to adults. Regardless of whether they were spontaneously breathing, whether they were ventilated, they all ventilated the uppermost lung preferentially. And in fact, they suggested that that pattern continued until the 20th year of life, which doesn't really make physiological sense, but that's what they said. And they were completely adamant that this is a pediatric pattern. It's completely uniform and repeatable between patients and for any patient from one time to the next. So I said it really makes sense, and while working clinically, I started to realize that my good intentions in positioning in patients didn't always work. They sometimes worked, but not always. So again, we started asking some questions. It's the why. And we started doing some quite cool research using fun toys. This is electrical impedance tomography. It gives real-time, non-invasive images corresponding to regional ventilation. You can see it's quite similar to a CT scan image. There's no radiation involved. It's completely safe to use at the bedside. You have to do some fiddling with images to make them look pretty though. At the bedside, you can't see a whole lot. So at the moment, it's more useful as a research tool. Essentially, you put 16 electrodes around the chest wall, and a small injecting current is then put into one of those, which is read by all electrode pairs and back projected into this 32 by 32 pixel matrix. And each of the pixels in this image corresponds to an instantaneous regional impedance value, which is very closely related to tidal volume. So you can quantify where ventilation is happening and how much is it changing, which is quite fun. So I was very lucky. I was invited to go to Kiel in Germany to learn how to use this new toy, and René's Frericks, who really is the doyen of EIT in the world. And very kindly and anesthetist offered to shave his chest for me in order for me to play with this toy, this tool. And it was autumn in Germany. It was quite cold. He also very did. For the ethicists, that was consent because he came to me and said, shall I help you? That was fine. And you can see that he is actually obeying the rules, right? If you look there on the left side, it's completely lighting up when he's lying on his left side. And in real time, literally it was 2 minutes apart, turned him onto the other side, and you can see he lights up the right side of his chest. So he's obeying the rules. So seeing this made me quite excited because, to be honest, I hadn't quite believed what I'd been told about adult ventilation patterns either. But anyway, he's following the rules, which is great. Then got home from Germany and thought to play around a little bit with some local guinea This picture is with my dear daughter's permission. This is Tia when she was 6 years old, who kindly agreed to put some electrodes on and play. Ida declined politely at the age of 3. She wasn't interested. So you can see it's not quite as clear as the adult pattern, but she's still following the same pattern. In left side line, the left side's lighting up. In right side line, the right side's lighting up. But you know, she's 6 years old, so maybe she's reaching an adult pattern. Maybe the 20-year threshold just wasn't the problem. So looking at some clinical practice. So this was a 3-year-old with Guillain-Barré syndrome and a right upper lobe collapse, which you can see on the X-ray if you're familiar with X-rays at the top, and you can see a corresponding area on the EIT image. So following the recipes I've been taught as an undergraduate, the rule is you put the collapsed lobe uppermost and then you do your physio. So being a good physiotherapist, this is what I duly did, and was incredibly disappointed to find that placing the child on the left side with the atelectatic lung uppermost made it worse. The volumes decreased. So this is without the addition of any physiotherapy. But actually when I put the collapsed lung at the bottom, it reinflated without any other interventions at all. So it's a bit unfortunate that after practicing for, I think, 14 years at that stage, I suddenly thought that I'd been getting it completely wrong for my entire professional career. But again, you know, if you're told you're doing something wrong, then you try to see how you can improve it. So together with Alison and Pat, who did this work for a PhD, we started looking at what the effect postural changes, positional changes had on ventilation distribution, from healthy children through to ventilated children and chronically ill children. So these are two of the preliminary papers that arose from that work. I thought it was quite exciting to actually title a paper and get it accepted, saying it's challenging a paradigm. It was quite fun. And these are the more classical EIT images, which aren't as pretty as the colourful ones, but are more correct, in fact. Showing two different children at the same age group in the same position, and just highlighting the fact that they are presenting with opposite patterns of ventilation. And in fact, when you look at it a little bit more closely, in sideline positions, only about a third of children followed the so-called pediatric pattern consistently in both sideline positions, whereas half of the children showed different preferential ventilation in different sideline positions. And similarly, in supine and prone, 86% of them showed different patterns depending on what you did with them. There was no consistent pattern, although the majority did show generally greater ventilation to the dorsal regions, which is to be expected. So sadly, we have come to the novel conclusion that there is no one pediatric pattern of ventilation. Ventilation distribution in children is highly variable, both between children and within a child. So if I take a measurement now, if I come back in 2 hours later, it might be completely different. It seems to be true for healthy children, for critically ill children across the spectrum. We haven't yet worked out what all those determinants are, and I think it's very complex. We haven't got those answers yet. So unfortunately, we don't have a neat recipe to follow. But I do like the suggestion that was made in very small print in a letter to the editor following Daly's paper by someone who had also clearly had the same observations in clinical practice. He had obviously noticed that children weren't really following these patterns, but he didn't want to disrespect anyone. So he just said, you know, in children of any age, if you don't see a good response in the corrected position, try the other side. And I think this is a very pragmatic suggestion, and it's one that I use, because you know, if you're going to start somewhere, well, let's start with what used to be considered the pattern, and if it doesn't work, try something else. That does mean, though, that you have to look at the child and you have to assess what the impact of the position that you've chosen is on that child. What we want to make sure is that the position chosen allows for the most ventilation in that child, it reduces the work of breathing, it optimizes their oxygenation, and provides opportunity for improvement. But we have to look at individual outcomes in order to determine if the position we've chosen is correct. So that was quite exciting. It's a little bit of excitement for us. If we look at some other aspects of airway clearance, getting the secretions from the peripheries to the central airways, conventional treatment used to, and I think still does in many cases, involve postural drainage and manual techniques. You can usually hear the physio before you see them, thunderous clapping, so vibrations and percussion. So, does it work? Well, if we again look at physiological plausibility, mucus is really quite cool stuff. It's a non-Newtonian thixotropic fluid. So if you agitate it, if you shake it, it temporarily liquefies, a bit like tomato sauce. So it makes sense that if you were to apply an agitation to the airways, you could temporarily liquefy the mucus, which could be moved centrally. So that makes some sense. But the use of percussion or any other external vibration is considered to be unfounded and unsupported by scientific evidence. We just don't know that yet. Well, it's quite cute. But we have some other interesting findings. So some people have said, oh no, but we've got the evidence, because look, these papers show that vibrations improve expiratory flow, and if we improve expiratory flow, that's improving mucus clearance. But is it showing that? What do you do when you vibrate? You squeeze. You always squeeze the chest. I think it's actually more likely to be about the squeeze effect than the vibration itself. So we know that velocity is inversely proportional to the square of the radius. So as your radius of the airways is getting smaller, your velocity can get faster. So by squeezing the airways, by lowering the radius, the volume, we can in fact theoretically accelerate airflow, but only up to a point. If we collapse it too far, there will be low flow, and that's not going to help you. So there needs to be that understanding. So this was quite interesting for me when I started thinking about it, because I realized that actually I'd intuitively been using the squeeze for all my years as a physio. At the end of a vibe, I always held the squeeze for a few breaths without really knowing why I was doing it. It just seemed to help. And we've now looked at specific techniques. We've named them assisted autogenic drainage. In infants and young children, we've looked at this in cystic fibrosis, and we've looked at it in acute pneumonia, where you actually change the lung volumes by an external squeeze. Take it down to low volume, and then you move it up to help the secretion clearance. And there are a number of techniques that are quite similar that have been described in neonates. When I was in China, that they were doing quite similar techniques, but they hadn't really named it. We've shown that these techniques do increase expiratory flow, which theoretically would increase secretion clearance. It reduces air trapping, and it favors the sigh. We were unable to show any side effects, harmful side effects, and in fact we showed a medium effect size in improving resolution of children who had lower respiratory tract infection with secretions, which was interesting. So we're still on the movement of secretions to the middle of the airways, and going back again in history to 1901, when this recipe book was created. So you can see at the back there's an advert for Sloan's liniment. I think that we would be a little bit suspicious of that sort of a recommendation today. But obscurely, in the same year, another recipe was written for chest physiotherapy in terms of postural drainage. That obscurely is still followed to this day without very much change at all. So in 1901, Hewitt and colleagues took a cadaver, they isolated the lungs, and they took a bronchial cast. They then poured fluid into the bronchial cast, moved it around a little bit, and said, well, these are the positions that we would have to do if there was a body attached to said bronchial cast. So we haven't got a living person that we're dealing with. We've got a solid cast that's not dynamic, that doesn't bear much resemblance to a person. But further on from that, some more researchers did some more in vitro studies. There was one small in vivo case series of 3 patients, adult patients, in the 1930s, by Nelson and others, who really extended this research a little bit, and they recommended that postural drainage positions, including inverted head-down positioning, should be used for patients with any secretion retention, And that positioning should be held or maintained for over an hour in order to allow jet drainage to occur. And this was the positional bed that was advocated. So I think if you read an article with this sort of a picture today, I'm not quite sure if you'd change practice as a result. Obscurely though, if you look at any physio textbook to this day, this is what they generally tell you to do. And you can hear the skepticism in my voice. I have lots of problems with this model. So the first is that thick secretions are not going to flow no matter how long you stand on your head. It's not how it works. You open a tomato sauce bottle for the first time, turn it upside down, you can look at it, and it's not going to land in your eye. It's not going to flow until you do something to it, which is why physios then tend to go and cap the lungs. Some of the other problems are that it's never ever been shown to work. There are no empirical studies, well-controlled studies, showing that this recipe approach to postural drainage makes any difference. And in fact, one small study that I found in the 1990s of 9 patients showed that 7 of 9 drained more from the bottom lung than the top lung. Those authors noted that in those patients there was increased ventilation to the bottom lung. Surprise, surprise. So it's more about the flow than the passive positioning to drain secretions. And remember, if we're thinking it's about the flow, we can't just change the recipe accordingly. In adults, the ventilation distribution might be fairly consistent, but in children, we know that it's all over the place. So using that recipe approach doesn't make any sense. We take that a little bit further, particularly related to the critical care population. We know that putting someone head down decreases their functional residual capacity because of largely the pressure of the abdominal contents on the diaphragm. The best lung volumes are achieved in the upmost, head up position, the upright position. And remember, we're wanting to open the lungs up and keep them open. This is particularly important in children where their closing capacity, that point where the airways really start to collapse down, it's very, very close to their functional residual capacity. So in children particularly, it's absolutely essential to keep their volumes maintained appropriately, to keep the lungs open, and prevent them going into closing capacity, closing volumes, and shutting down entirely. So really, it makes no sense to put children head down for secretion clearance or for any other use. And of course, the other problem is that head down positioning causes harm. There are a number of serious side effects of head down positioning, as I said, no evidence of benefit at all, and was actually advocated as a form of torture and slow execution for a few centuries. It's not pleasant. So for a number of reasons, as that I've gone through, including the fact that the head down positioning is potentially dangerous, the standard positions have never been shown to work, I really have strongly advocated against this practice, and I think it needs to be relegated into the dustbin of history. I'm pleased to say that most physios now in Europe agree, and they do not use these positions anymore. We still have to get the message out throughout South Africa and stop that practice in South Africa. So conversely, we don't have to put them head down ever. In fact, we don't even need to put children flat. By putting them head up, we're maintaining volumes, we're preventing things like ventilator-associated pneumonia, we're promoting communication, we're preventing aspiration. There are huge advantages in keeping children upright. So while we can use positioning to help us move secretions and to optimize our ventilation perfusion, we really should be looking at keeping them head up all the time. But that brings me to the more important point. So again, long ago I started thinking it wasn't about sustaining any one sedentary position for any length of time. There's growing evidence that introducing movement to cardiopulmonary therapy, even whilst in the ICU, improves patient outcomes and prevents a number of complications of critical illness, including enjoyment. This was work done by Claire Proctor and ourselves a year or two ago. We've seen that with improved care in the ICU, there is a steady decline in ICU-related mortality, particularly in high-income countries, which is in the red of this graph. We have a little way to go in low and middle-income countries, but in fact, death, and it's a good thing, death is becoming a rare event in the ICU, and that's wonderful. But we also know that just not being dead doesn't mean that you're alive. And there are many adverse consequences of pediatric critical illness. These have been described in the adult context for many, many years as the post-intensive care syndrome, and Joseph Manning and colleagues recently applied this to children in the fixed key framework. So critical illness with a number of different factors has been shown to have potential consequences on physical, cognitive, emotional, and social health that affect the child adversely, as well as the family, the parents, and the siblings. The trajectory of recovery is also highly variable, with children taking days, weeks, months, and even decades to recover. So this is a combination of two things. It's the critical illness itself, the treatment we give, and the effects of immobility. We know that immobility alone can adversely affect every single organ system. It can cause cardiovascular problems, including postural hypertension, deep vein thrombosis, pressure sores, gastrointestinal complaints, neurologically, depression, anxiety, forgetfulness, ICU-related delirium. The respiratory tract, just lying still, can cause respiratory tract infections due to pulmonary stasis and pulmonary emboli. And from the musculoskeletal system, we cause muscle atrophy as a result of keeping children still in the ICU and overly sedated. The muscles actually atrophy significantly within 1 day of admission to a pediatric critical care unit. We actually see similar effects on the musculoskeletal system during spaceflight in zero gravity, interestingly. So you may have seen images like this of astronauts returning from the space station where they have to be lifted out of the capsule. They're not doing that to be nice, they're doing that because the astronauts cannot stand up by themselves due to muscle weakness and because of danger of actually fracturing long bones on weight bearing for the first time. So bone formation and resorption or remodeling is a continuous process that requires loading and unloading of the long bones. And if you immobilize someone, if you put them in bed or send them up to space, you actually take away that process. And so you end up with bone resorption outweighing bone formation and the risk of fractures. So it's absolutely essential that we need to get children moving, even while they are critically ill in the intensive care unit, to try and limit the complications of inactivity, which compound the critical illness effects. I do believe that Red Cross Hospital has been ahead of our times. So the move to move in ICUs has only become topical in the last 10 years or so, but we have always done it. It just made sense. But we didn't have the protocols in place at the time. The boy on the right, Gavin, was one of my very first patients who taught me the most, I think, about pediatric critical care practice. He spent months in our ICU after sustaining a C1, C2 subluxation that rendered him completely paralyzed and ventilator dependent. So once he had stabilized, although he was still on a ventilator for the vast majority of the time, he mentioned to me that he always wanted to swim. So we thought, well, why not hydrotherapy? Unfortunately, at the time, the only hydro pools in British skier. We had no transport ventilators at that time. He was on a bird ventilator, for those of you old enough to remember in the audience. But perhaps it was just a reflection of my naivety. But we thought, well, why not? I had a beetle at the time, and so Gavin, PICU nurse, a portable suction machine, sped trachea. We had a nurse there, his mom, we had Gavin, we had a registrar, and myself. We bundled into the back of my beetle, and we drove up to Prof and we did hydrotherapy. And it was fantastic, because this little boy who couldn't sit in the air was able to walk in the swimming pool. More recently, Samir and colleagues have made hydrotherapy a little bit more accessible in the ICU without disconnection from the ventilator. And perhaps this needs to be our next paper. When I presented some of my standard work at an international conference some years ago, it was met with a lot of gasps in the audience. We could never do that here, generally in the United States. They were so scared of litigation, they were so scared of things going wrong. And clearly you do need to be safe, you need to be careful, but there is the potential to do so much with these children. But because of the gasps and the scared reaction from physios, we got together an international group to actually develop practice recommendations for early rehabilitation in critically ill children, to provide safety parameters for people in order for them to actually start moving children in the ICU. So we do recommend that rehab should be initiated as early as possible after ICU admission where it's appropriate, and using the appropriate movement for the child's age, their illness, their condition, and you can start appropriate level of activities very low down. You can start with passive movements, for example, positioning, and then move up to more active activities that require more involvement on the part of the patient. All of the activities listed there is rehabilitation. We also can't consider PICU rehab in isolation. So most of you will know the saying, a single twig breaks, but a bundle of twigs is strong. And in fact, early mobility and exercise is part of the ABCDEF bundle of care. We need to get everything right for our children in the ICU. If we aren't appropriately managing pain, if we aren't preventing delirium, if we are overly sedating our children and not allowing them to move, we are not also going to be able to get them out of bed. And all of this requires family engagement and empowerment. You have to get it all right to be effective. So delivering this level of care clearly requires an holistic approach, which also needs an institutional culture that supports rehabilitation in the ICU. I do believe it can be achieved. You just need buy-in from your interdisciplinary team, from your tribe, and you can make it happen. And that includes the family. I believe it's possible to provide care that helps as many children as possible survive their critical illness or injury, whilst also ensuring that they're able to thrive after discharge, achieving a high quality of life despite all the barriers or impairments that may be present. And furthermore, that this is sustainable in the long term. So after the past 26 or so years of my professional practice, I've seen and played a small part in leading a move away from an organ or disease-specific focus to physiotherapy in the ICU. So as survival in the PICU has improved, our clinical and research focus is shifting appropriately to an increasing focus on optimizing the quality of survival and long-term recovery. And so I think it's quite clear from this journey that the concept of routine chest physio, and in fact the concept of routine practice generally, is inappropriate, outdated, and has the potential to cause substantial harm. I think as physios we need to bin the recipes. We need to start using proper clinical reasoning in the PICU physio practice. And while we clearly need more research, I am proud to have played some part in tossing these in. And I've recently presented a new paradigm in which I encourage physios to stop separating body systems, to start thinking beyond the lungs, and treating children as whole, entire beings with interrelated, interdependent systems. We can affect the lungs without ever touching the chest. If you're positioning a child with cerebral palsy for neurological reasons, you are also impacting on ventilation and perfusion. If you're working to strengthen skeletal muscles, you're also strengthening respiratory muscles. You can also help to wean the child from the ventilator in that way. Because after all, we're faced with whole children with complex problems, and the care we offer must be planned accordingly. And it turns out that that 1915 advert I showed you wasn't all wrong. A century later, Forbes listed physiotherapy as the 9th happiest job. And obscurely, Tinder users were also more likely to swipe right, which I think is the good one. Physios than any other profession. So clearly we are getting something right. So I don't feel that I'm at the end of my journey by any manner of means. I still think I'm in the starting blocks. But this journey would not have been possible without some very important people. I've learned something from every person I've worked with in all clinical and research arenas, locally and internationally. And I've highlighted some of the very special people here, my special mentors and role models. Some of them are no longer with us, but their legacies live on. Specifically to Andrew Argent, who has been my mentor for since I first started working at Red Cross. He supervised my PhD, and for better or worse, shame, he still walks beside me in the research we do today, and has been a continual support, always kind and always wise. Thank you, Andrew. People like Max Klein, who allowed me to ask questions in the ICU, allowed me to join the registrar rounds and become as annoying as they were to him, taught me a huge amount. In the ethics field, Mark Blockman, Teresa Burgess, Jane Booth, you taught me the most of patient and family-centered care and of thinking out the box in treating children with complex needs. Thank you very much for that. To Manette, my entire nursing tribe, the physios at Red Cross, to my CF team, in the past the late great Joe Island, Tony Westwood, currently Marco, and the entire team. And most importantly, I see one of them here, my patients who I've treated over the years. You have taught me the most. I would say more, but I can't. So, thanks to my family and other animals, I'm very grateful to have my parents, Jasper and April, here today, my siblings, Douglas and Linda, who are overseas and hopefully attending virtually. Hi. Thank you for all you've done for me. And my wonderful nuclear menagerie, which you've heard about. This isn't actually my entire menagerie, there are more of them. My husband, Carl, my two incredible daughters, Tia and Anna. Thank you for helping me keep the balance and know where my priorities are. Your unwavering love and support, and not only tolerating my craziness, but actually encouraging me through it. I really do feel blessed. And last but not least, to everyone who is here today, physically and virtually, I thank you.